It's the 17th of May, 2024, and this is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. I want to begin with a little podcasting note and thank all of you for your support and your many kind comments about listening to this podcast and what you may get out of it. I must say this began as a bit of an accident, and I really didn't know what podcasting was, and in the beginning, it seemed really strange that I was talking to myself, but I've learned over the years that I'm talking to you, colleagues and friends, and that we're sharing information that's kind of important to what I do and what you do. The fact that you're a regular listener is not lost on me. It's a true honor, and your reminders of your engagement in this is impetus for me to want to continue to do well. If you like this podcast, please be sure to give us a thumbs up on wherever you listen to your podcasts. So this week, we're going to do a 2-week catch-up on news and information. And I think we're going to discuss, can we prevent gout? How about maybe prevent pulmonary fibrosis? And even better, use vitamin D to prevent or even treat psoriasis? Oh my, this week in the podcast. Let's begin with one of my favorite quotes. Don't you know who I am? Something I try to use at the airport or in a new city, or even better when I go to the emergency room. I found a good tweet that came from Eric Topol on a military study of 1.5 million emergency department visits and what exactly happens to high-ranking or high-powered patients when they see the ER doctors. And as you might imagine, this study shows kind of clearly that, yeah, they get preferential treatment. They get an easier time, more pain meds, more leniency, less hospitalizations. There's clear-cut differences between how blacks and whites are treated, and it's a bit of a reminder. Yes, I do. I know I don't use that line, don't you know who I am, because no one ever does. But I do like it when I've gone a few times to the emergency room or the hospital, and it's like, oh, Dr. Cush, and that whole thing happens, and yeah, things go smoother for me. And it's one of the reasons why I advocate strongly that patients who are not physicians need a patient advocate, someone who understands healthcare to navigate it, because we know how to navigate healthcare, but average patients do not. So it's a reminder for us to be on our best behavior and treat everyone the same, not just the admiral and colonel, or whatever the equivalent is in your world. I like this study from Dan Solomon and colleagues that was basically an EHR study of over 5,000 individuals who had prediabetes, and then compared them, because they were starting on Metformin, compared them to almost 14,000 who did not start on Metformin. And with nearly 4 years of follow-up, they found that the risk of developing incident gout was lower in people taking Metformin, 7.1 versus 9.5 per 1,000 patient years, a 32% reduction by hazard ratio. And when they looked at other parameters like serum uric acid levels or CRP levels, they were not different between the groups. So something's going on. Diabetics are probably at higher risk. I think gout's in there, and hyperuricemia is in there in the metabolic syndrome constellation. And such patients are probably at greater risk for gout. But being on Metformin, is it from like IL-17, Th17 effects? It's not from lowering uric acid. So I think it's an interesting study that I'd like to see done again, but prediabetes maybe should be treated more aggressively. A French study looked at the risk of developing either polymyalgia rheumatica or giant cell arteritis following the use of the COVID vaccine. They had like 3 versions of the COVID vaccine. This is a national insurance claims, not insurance claims, but a national database. And they found that the relative risk of PMR. They found 179 cases in millions of people that were, vaccinated. 179 cases of PMR and 54 cases of GCA. The relative risk was 7.1 per million for PMR and 2.1 per million for GCA. And they sort of put forward the possibility that these were related to COVID vaccine, mainly because of the temporal relationship, the onset of these events and disorders within 7 to 10 days for the vast majority of people, within 7 to 10 days of getting the vaccine. The problem is that the population incidence of GCA is between 1 and 10 per million in low-risk countries and 10 and 30 per million in high-risk countries like Northern European, Northern Scandinavian countries, Minnesota, etc. So these incident rates of 2 to 7 per million is below the population expectation. So again, the age-old question, or the new age-old question, is that following COVID infection and or vaccination, are we seeing more disease, more specific diseases? And I don't know that we have great evidence of that. I do know that maybe because of the sort of captured cohort we became during the pandemic experience, that maybe we're counting the events more carefully or more closely. Hard to know, but I don't go along with the summary of this paper, which was that there's a relationship there. The Osteoarthritis Initiative is a long-standing study looking at the development of osteoarthritis in a cohort without disease. In this particular study, a retrospective cross-sectional study of nearly 2,600 patients, they were older, they had a fairly normal BMI of 28, that they found that the population that was involved in regular bicycling, again, these are older individuals, regular bicycling, 48 months follow-up, they had significantly less knee pain, 17% reduction. And these numbers were significant. Significantly less radiographic OA developing, a 9% reduction, and a 21% reduction in the development of symptomatic OA. Yes, bicycling should be encouraged. I like this data because I have knee OA and I do a lot of bicycling. I try to do at least 20, if not 50 miles a week. Since 2010, a French national insurance database study looked at the use of drugs used to treat GPA and MPA to see that in two different time eras, 2010 to 2012, I think was the first era, and the second era was in 2014, 2017, where the drug use changed over times. And the cohorts in the first era was 977 patients, second era 1,133. Again, most of those are GPA more so than MPA, but they showed a clear-cut increase in rituximab use over time and less use of azathioprine. So the rituximab story has been an interesting one, has it not? It really has transformed the management of ANCA-associated vasculitis, both as an induction therapy and as a maintenance therapy. And azathioprine, which I guess would have been more relegated to maintenance therapy, has kind of fallen by the wayside. Interestingly, in this analysis of two different time eras, there was no change in the use of either methotrexate, cyclophosphamide, or steroids over time. So I buy into this. I think you would as well. A study of ankylosing spondylitis patients shows that there's a higher risk of pulmonary embolism. This is a retrospective cohort study of 5,800 AS patients and 28,000 controls, and they looked at the risk of, or have the incidence of PE prior to AS, and it was low. It was compared to those who had AS and those were matched controls. It was 0.4% in AS and 0.2% in controls, and that was not significantly different. However, following the diagnosis of ankylosing spondylitis, spondyloarthritis, PE incidence went up, 11.6 in AS versus 6.8, and that's per 10,000 patient years, so it's not a high incidence. but the adjusted hazard ratio is 70% higher if you had ankylosing spondylitis or SPA, and that was significant at 0.001 or less. So it follows what we've been talking about in the past, that the risk of VTE events is related to inflammation and sometimes underlying diagnosis. Is also related to age, prior PE events, and, of course, we're worried about JAK inhibitors. But again, the bigger issue, I think, is going to be age, inflammation, inflammatory diagnoses. And having a prior PE would be much more likely to give you a future risk of PE or another VTE event than would be the JAK inhibitor. But we've already talked about that, have we not? Very interesting study, I think this was in Nature, talked about, it was an animal model, and it showed that IL-22 may have protective effects against the development of pulmonary fibrosis. Moreover, they did a study of 66 new or consecutive RA patients, half of whom had interstitial lung disease, and they compared them to 14 controls without RA and without ILD. Serum IL-22 levels was significantly lower in those who had RA-ILD, and it was obviously inversely correlated with the development of ILD and the severity of ILD. IL-22 is a cytokine. It has some pro-inflammatory functions, but it's made by T cells and other non-hematopoietic epithelial or stromal cells. It's thought to promote inflammation, but also play a role in tissue repair and tissue regeneration. So it's high early on in PSA and RA, but it's low in RA because of a failed reparative effort, and that's maybe why they get the ILD. This could be a potentially very useful biomarker in assessing outcomes in patients with RA, ILD, and or interventions. Be looking forward to that in the future. An MGH study compared 1,100 acute CPPD patients, pseudo-gout, with 3,700 controls, and found that if you had CPPD, you had a twofold increased risk of fractures, mostly in the wrist, where you get a lot of CPP disease, especially acutely. It was, a hazard ratio 1.8, 80%, or almost double the risk, 11.7 versus 5.5 events being fractures per 1,000 patient years. This is also going to be more likely if you were on steroids, promoting a fracture risk, and osteoporosis, an inherent fracture risk. But just by itself, CPPD became a risk factor for wrist fractures. That's kind of a little bit of a tongue twister. Risk factor for wrist fractures. 3 times fast, go. Speaking of gout, or we were speaking of pseudo-gout, the RISE registry did a study of an analysis of 700 Pegloticase users. With 14 months of follow-up, they found 18% were taking immunosuppressives. Immunosuppressives mainly being methotrexate. Next most common was mycophenolate. Least common was, like 2%, was leflunomide. But Pegloticase treated gout patients who were on immunosuppressives had less discontinuations from Pegloticase, they did not have more toxicities or more lab abnormalities. And I find that very interesting. By the way, I don't think you should be using leflunomide. Leflunomide is uricosuric, and leflunomide could potentially lower the uric acid levels, and you don't want that happening when you're taking Pegloticase, because it is the rise in uric acid levels lets you know that you're getting into trouble with anti-PEG antibodies, right? So don't use leflunomide. But yeah, methotrexate, mycophenolate, brilliant. This is a sub-analysis, open label, whatever, but I think it has instructive value. But only 18%. Me, whenever I've used Pegloticase, I'm putting them on methotrexate or mycophenolate right from the start, especially if I'm intending to give the patient therapy for 6 months or more, and that's obviously with their consent. I asked a question recently of a gout expert in another country. Do you think Pegloticase is being used enough or not? And they said, well, I wish I knew, because that drug is not available in their country. And I think I think that we're not using Pegloticase enough. I wish I had used it a lot more. I know I intended to use it more, but often the patients that I wanted to use it in were so sick, they never got on the drug. Or even worse, a few died before I could give them Pegloticase. It's a dramatic drug for dramatic patients. We should be using more of it, in my opinion. A review of the literature this week disclosed a JAMA Dermatology review article, year in review. And I looked at what their big papers were, and the number 3 top paper in 2023, according to Citation Index, I believe, was this study on vitamin D utility in 122 patients with plaque psoriasis. Now, they had fairly mild disease with a PASI score of 3.1 or something. Moderate disease is like 5 or higher, but this is kind of on the lower side. And to be enrolled, they had to have a vitamin D level under 24. The patients who were enrolled had a median vitamin D level, I think 14.9. They were treated with either placebo or 20,000 units of vitamin D weekly for 4 months. And this was all during the wintertime. But using vitamin D had no effect on PASI scores or outcomes or MD globals or DLQI. It's like a functional hack score for the dermatology and psoriasis populations. Nor did it distinguish what happened to 25-hydroxy vitamin D levels. In fact, they said that the rise in 25-hydroxy levels was less than expected based on other studies of this sort. So maybe it didn't prove the point. This goes along with my, bias that, we rheumatologists, you rheumatologists love vitamin D and everything about it. No, it doesn't treat pain. No, it doesn't treat cancer. No, it doesn't. And I did post a review this week of consensus guidelines where it makes some crazy claims, but I posted it anyway just to feed your vitamin D ego. But I'm not a big believer. I think vitamin D is vitally important. I take it every day. It's great for bone health. It's great for immune function. I don't know that it treats anything. Michelle Petrie has shown some data where it might treat lupus. But here's a paper that says it doesn't improve psoriasis. I'm willing to continue the argument and take your disdain and rotten apples when you throw them on stage at me. So what about GI perforations? It is a warning for IL-6 inhibitors. It's also a warning for all the JAK inhibitors. So the package insert risk, I believe with the IL-6 inhibitors, the 2 that are approved, cerulumab and tocilizumab, is 1.1 to 2.6 events. And this is usually lower GI perforations per 1,000 patient years. And that's kind of along my experience. I got tons of patients on IL-6 inhibitors and JAK inhibitors, and I don't see GI perforations. It's come up a few times, and those are people who usually on steroids also have a history of diverticulitis, not diverticulosis. But anyway, this particular, and the PI data, I only found good data for upadacitinib, and it's 1 to 2 per 1,000 patient years. Again, that's about the right number, right? Well, a study that came out this week from France, an insurance population study of 40,000 patients taking either a JAK inhibitor or adalimumab, found no difference between them. There is no warning for lower GI perforations with the TNF inhibitors. And that the incidence rates were 2.1 versus 1.1, 2.1 for JAK, 1.1 for TNF inhibitors per 1,000 patient years, not significant. So is this a real worry? Based on these numbers, based on the package insert numbers, based on this population data, probably isn't a real worry, but I think you still have to factor it in your decision making about using either a JAK or an IL-6 in someone who has a history of GI perforations or diverticulitis or steroid use or any combination thereof. You may have other options that may make more sense. I want to end sort of with 2 different reports here. I was at the Yale great conference run by Rob Schoen and Rich Bucala and their colleagues at Yale, the International State-of-the-Art Rheumatology Symposium. I got to go and hear great speakers, and Georg Schett gave a fabulous 30-minute presentation on the CD19 CAR T cells and 3-year follow-up, plus a bunch of other patients that had, besides lupus, myositis, and systemic sclerosis, with really impressive results. Rapid depletion of B cells with reconstitution of B cells in all those patients, and no flare of activity. As you know, when he gives CAR T cell, they stop steroids, they stop all DMARDs, hydroxychloroquine, azathioprine, all the nasty things they were taking, and they've not been on any therapy since. The interesting thing about the CAR that I learned from Dr. Schett, CD19 is expressed on pre-B cells from the marrow all the way up to circulating B cells, but it is not on plasma cells or tissue plasma cells. It's also not on plasmacytoid dendritic cells. And prior to this brave experiment with CD19 CAR T cells, I always thought a lot of lupus autoantibodies and immune conflicts were generated by plasma cells, tissue plasma cells, and driven by plasmacytoid dendritic cells, giving you an abundance of type 1 interferons. Turns out that they're at the effector end, and the proximal end is the B cell, at least according to this experiment. We're going to embark upon an era of a lot of CAR T cell research being used in autoimmune disease. Will it be as effective in other disorders? Will it be as safe? Because CAR T cell therapy for cancer is kind of nasty, got a lot of side effects. But the Dr. Schett's experience shows this has been really amazingly well tolerated, and no episodes of cytokine release syndrome. The last report was in JAMA Open Network on the risk factors for hydroxychloroquine retinopathy. This is a nearly 5,000 patient cohort starting new hydroxychloroquine with baseline eye screening at 5 years, and then every thereafter for up to 15 years. And they're looking at the rates of incident hydroxychloroquine retinopathy. Overall, 125 patients, or 2.7%, developed the retinopathy with 15 years of follow-up. Risk factors were older age, starting at age 45, going up with each decade, ranging from a hazard ratio 2.5 to 5.6. Women were nearly fourfold higher risk, having CKD grade 3 or higher, twofold risk, tamoxifen greater than a threefold risk, and Asians and African Americans had a 5 to 15-fold risk compared to non-Hispanic whites. Again, this is something we need to know and understand in following our patients, and know the new guidelines would say get baseline and then screen them at 5 years if they have no high risk factors or otherwise any problems. Anyway, that's it for this week on the podcast. Hope you've enjoyed it. EULAR's coming up, less than a month away. We're going to have extended coverage at EULAR. Be sure to go to the website to follow us during EULAR and to follow these reports and their citations. They're in the show notes on Room Now. Good to be with you always.